Open.
Outspoken.
It's ophthalmology off the grid.
An honest look at controversial topics in the field. I'm Blake Williamson.
I'm Gary Wörtz.
Thank you for listening to a new episode of Ophthalmology Off the Grid. In this episode, Dr. Sebastian Heersink shares his case example with Drs. Blake Williamson and Gary Wörtz of how to avoid a potential surgical horror story during his own father's cataract surgery.
Hey everybody, welcome to another edition of Ophthalmology Off the Grid. Blake Williamson and Gary Wörtz hanging out here. Gary, how's your month coming? It's September now. How you feeling?
Yeah, I mean, football season is in full swing. Kentucky has pulled off a couple of wins. They're 2-2. Lost a heartbreaker to Georgia a couple weeks ago. But you know what? We're feeling okay here in the Bluegrass. So how about down in Tiger Country?
It's hot here, man. Yeah, I watched that Georgia game. 1 point. That's unbelievable. No, we went to the game last weekend. It was like 113 degrees on the field. They're just not meant to have football games in the daytime in Louisiana in September, I don't think.
I think there's something to that. Tell us about our guest that we're so excited to be interviewing today.
Well, so this is my dear friend, Sebastian Heersink. For those that hadn't met Sebastian, he and his family are a generational practice out in Dothan, Alabama, and all across Alabama and parts of Florida. Massive practice down there, and just some of the coolest, most interesting people. I've had a chance to go be in surgery with them, and they've had a chance to come watch me operate, and just have been always kind with sharing their time and ideas. And Sebastian, when we thought about horror stories and just tragedies in the surgery suite, I thought about you, buddy.
Yeah,
okay.
My name was at the top of the list.
Gary said it best. I mean, really, this season has all been about handling challenges, and everybody, when we talk to them, you realize that we all face a lot of the same stuff: unhappy patients who are doing very well objectively but subjectively unhappy, or VIPs like your parents or your loved ones that you operate on and have challenges with, or just those nightmare cases that we all experience if you do enough surgery, like I know that you do. And so that's really what this is about. So I appreciate you being brave enough to come on and share some insights of what you've gone through.
Yeah, no worries. This is a safe space, right? I can,
Yeah, no, I actually don't think anyone's listening, so that it actually is a pretty safe space. But tell us, before we get started, for those who don't know, I mean, Blake kind of said it, but tell us a little bit about your practice, how long you've been in practice, kind of the things that you're excited about in your practice, and kind of what your day-to-day looks like, and we'll get into some stories.
Yeah, for sure. So thank you. So I joined my dad in practice 13 years ago, trained up in Philadelphia at Wills Eye Hospital. Basically do a lot of refractive cataract surgery, just like you guys, but also do some other things. About 6 years ago, started a clinical trial division. So we do a bunch of clinical trials in the cataract world, in glaucoma drug delivery, in cornea, some cross-linking, and so that's been a really interesting kind of, not a side project, but it's added a lot to our practice. I am fortunate enough, I work with a wonderful optometrist 4 days a week. I'm in the OR, four half days, and then I have a full day of patients on Friday. So I'm still working 5 days a week, trying to work more like you, Blake, get some wisdom and get a little bit better balance. But I do probably about 250 cases, cataracts a month. So we stay pretty busy at it, and with that, you get enough opportunities to goof things up. And so,
get yourself in trouble from time to time, right?
Yeah, exactly. But like one of the beauties of doing so much is that as soon as something goes bad, you got to jump right back in. I know you guys feel the same way. Is first thing you can do, best thing you can do if something goes wrong is to jump right back in and not have to think about it for a week or whatever between cases. So, we appreciate the opportunity to keep going, and just don't quit on it.
Yeah, it's the Top Gun. Like you have a flat spin, you got to get him back up in the air.
Exactly.
So, right?
Exactly. Yeah.
All right. So we've talked this season, Blake, to a number of friends, new and old, and it has made me feel honestly like I'm not the only one. I'm not the only one who goes through these things. So this is again another therapy session. And Sebastian has texted us with a really interesting list of some challenges, should we say? Where should we start, Blake?
Well, I mean, I think that what's one interesting piece would be start with taking care of your dad.
Yes.
The great
Yeah.
Marnix Heersink. I mean, it's
A podcast member in the past.
He's been on, and I'm gonna be operating on my dad soon. So I'm just curious to see what y'all chose and what went wrong and how you fixed it, not once but twice.
Yes. So I think that was something that, a lot of different things in your life that get you, stressed or challenged. And I kind of put it in a basketball analogy. It would be, you're no time on the clock, you're down a point and you get 2 free throws and everybody's watching and think, okay, how do I handle this situation? And so my dad never does things small. It was actually his 3rd procedure of the day when he got his cataracts done. He had gone for to get a knee scope and then got a trigger finger worked on. And then he came back the middle of the week on a Wednesday. He's like, hey, are you operating? I was like, yeah, how'd your scope go? I was like, oh, good. You want to do my surgery now? I was like, what? Now? Sure. So it was good in that, we'd already looked at, lenses and all that stuff, but I didn't have the dread of, a week or 2 or 3 having it on the schedule looming over you. So I think it was really kind and thoughtful of him to do that. Kind of surprised me a little bit. I was like, okay, sure. So cleared it with anesthesia. They gave him just a little bit because he already had, this is literally his 3rd procedure of the day. So
this is giving me anxiety right now. I feel like I need a little bit right now.
Yeah.
What time of the day is this? He's already so he had a knee scope, and what else did he have?
So this is the second city of having. So he was in Birmingham early in the day, had a knee scope and a trigger finger worked on by 2 different surgeons.
So he's like, I've got 1 day off. I need 3 surgeries. We're gonna just make this happen.
Yeah. And says, I'm feeling pretty good. I'm not feeling groggy, so I'm just going to come to the office. I hope my mom dropped him off. I hope he didn't get here on his own. And he's like,
Ubering.
Yeah. So, and we talked before about saying, okay, well, I'm a technician. You know way too much about this. You pick the lens. I will put it in and do it. So my brother is also a dentist who's worked on my dad before. He says, he's so curious, which is wonderful. One of his best qualities. But while he's working, he's asking me, all right, so how big is a rexus? And as I'm get him under the scope, and I almost just want to say, shush. I want to just focus on the technical aspect, moving the microscope. Just thinking about this is just an eyeball, not all the importance of what this eyeball is and who it's attached to. And so how's it going? I see this now. Oh, okay. Are you break it? Are you cracking the lens now? Yeah, exactly. So luckily surgery, all went fine. Things were good. Finished up, said, okay, great, congrats. And we do this funny thing, which is we take a picture with people afterwards, and he looks a little disheveled after his third anesthetic. And then I check him back the next day, everything looks good, but his lens is just a little decentered. I mean, it was in the bag, in the capsule. I said, oh, goodness gracious. So I was left with the decision of, is it good enough? And it's not going to be good enough. Or do we go back and kind of reposition it? And if so, where do we do it? Sometimes we do things in the office and numb people, and he's very good about being still. But I just thought to myself, if something goes wrong, I want to do everything by the book, lined up, etc. So,
and what lens was it, Sebastian? What lens did you put in?
The Apthera. So
you did an IC8 Apthera lens, and
IC8, yep.
So that's why the decentration mattered. It wasn't like it was like a multifocal where maybe the button went perfectly center and you could have waited a week or 2 to see, or toric,
Yeah, exactly. So it really needed to be quite nicely centered. So he was just it's good, and he's just like as a dad trying to be upbeat and positive, but you could just tell. I said, how about we just go and just nudge it over? He said, oh yeah, let's do that.
Yeah, let's nudge it.
Yeah, so this day post-op day 1. We go back, kind of nudge it over. It would look better, look perfect in the OR. Said, okay, let's give it through the weekend. then it starts to kind of decenter the other way, almost like trying to put something on a balance beam, and it was now a little bit more nasally decentered. So, okay. So went back a third time, and this time what I learned was, why don't we put some myocol in? Because when I try to center stuff, I have people look at this light. I flash the light, say, look at the light, and I put myocol in at the end, and that took care of it. Gave him a massive headache, poor guy. But at least the lens is good. It's well centered, and I think it's that part's been doing well. In his other eye, we used a monofocal lens, and so that didn't have all the issues, non-toric, so didn't have to worry about all the challenges of getting the centration perfect.
Yeah. How many times have you exchanged him since then?
Not yet, not yet.
So he's happy. So he's happy with that combo. He's got good range. He's not using reading glasses much.
Yeah, no, his near is great. Part of the basic having him pick was with his other eye. I said, all right, what do you want? Far, near, intermediate. What do we do? So plan for distance. And this was one of those things where, we went back and forth, and he wanted 18. I was like, I think 17 and a half is going to be a little better. We debated between the LAL and just an off-the-shelf monofocal. We were going on a trip overseas for Christmas and New Year's with everybody, and he says, I don't want to wear the glasses and the goggles and being in multiple places. So ended up going off the shelf, and I think now I got to ask him, would he do that again? Because he ended up a little myopic in his his dominant eye. So for nighttime driving, he says, I do better with glasses, and he takes it off. He's got fabulous near vision, good up close computers is fabulous. But when we played golf the other day, and he was wearing glasses for that, and he said, I just wear more comfortable wearing glasses to see distance, and definitely for the nighttime driving. So
yeah, I think a good sort of if I'm someone who doesn't know Sebastian or Marnix, and I'm listening to this, I'm thinking, well, or maybe I'm like in training or a resident. I'm thinking that doesn't sound like a horror story. Like that sounds like pretty straightforward. It sounds like you just fixed it. I think that where the learning moment with that is, though, is that the reason it doesn't sound like a horror story is because you were so calm, cool, and collected in doing something about it. As you said at the beginning, we kind of, at least in residency, and I just feel like a lot of our colleagues in general ophthalmology sit on their hands a lot, and they would have sat there and saw it slightly decentered for weeks or months, and they would have optimized the ocular surface, quote unquote, and they would have done everything except just go back into the eye, right?
Yeah,
and it would
yeah,
and it,
sure.
and it would have turned into a horror story for people listening to that, thinking, and I'm not being ugly about it, but if you're thinking to yourself, yeah, I probably would have just kind of waited for weeks or months, and I don't know if I would have gotten a second time. It sounds like you're doing too much. Like it would have turned into a horror story, but it didn't, because you were so decisive and you landed the plane. Somebody's got to land the plane, and if it's not going to be you, it's not going to be the guy down the street or the gal down the street, And so we have to understand that as refractive surgeons.
Oh yeah, no, for sure. And I think that's something that I couldn't agree with you more on. If something's not quite right, it's not going to get better. Occasionally stuff will, neuroadaptation or whatever, but if you look and mechanistically something's not right, I think our job is to go and fix it and explain it to people. That's the other big important piece, is saying, hey, what wasn't quite right and why, and we have those discussions. And I think as long as people know that you are going to be there and walk with them till it's right, or till it's as good as you possibly can get it, people have such incredible patience for you to go, and that's what I love about our job, is we get to fix stuff, we get to problem solve. And sometimes the problems are easy, 1 + 1 is 2, and sometimes it's a differential equation, and it takes a couple cracks at it. But the ability to jump in, and like you say, the decisiveness to do that, I think, is something that, as a patient, I want that.
No, I think that's part of it. Is your dad actually sounds like he was a pretty reasonable patient, and that's half of the equation. A horror story isn't necessarily anything going wrong surgically. It can be someone who just perceives that the result is different than what they had anticipated. And you have a couple of stories, I think, about patients who, on paper, things look pretty good, but in their mind, something is wrong, and perception becomes reality. Why don't you walk us through one of those stories?
Yes. I think that's something that also, for sure. So recent one, there's a gentleman who's about a +3, 20/30, best corrected. He's about 55, early NS. Like, geez, +3, this is fabulous. He's going to be super happy. Toric lens, he's worn glasses for his whole adult life. And so go in, he's 20/20, J3. This is with another monofocal, surprisingly good near vision with a toric, and he comes in and says, "This is terrible." So I'm walking in. This is a celebration moment. Like, look at me, we're so great. Our team kicks butt. And he was so unhappy. I got this glare over to the side, and just, I can't live like this. And I'm thinking, can't live like this. I would, 80, 90, 100% of people would trade to have these kind of numbers. And so I think for them, the first thing that I find is just validating them, saying, yeah, hey, I know these numbers are, they look good to us, but it's a black letter on a white background, maximum contrast. It's not your vision. And so once people hear that and hear that you can relate to them, that tells them that you're really going to listen. So anyway, this person's subsequently said, all right, Disphotopsy, explained that to them, drew it all out, and said, okay, let's do a piggyback. Did that. It was 10%, 20% better, still really, really unhappy. And so we took the piggyback lens out and decided, he actually, which was the mistake, was to say, all right, he had a YAG in between, because I was like, yeah, the PC, he's a young guy, he's getting a haze. So I was like, maybe that's part of it. So after the piggyback, did a YAG, still not happy. So just recently didn't do an exchange, but I went back, took the piggyback out because he was a little bit too myopic, and moved the IOL haptic, or he left him in the bag and moved the optic anterior to that. And he's better, but still, 20, 30% glare, fuzz, halo. So we're going to now say, hey, the next step is, to go do an exchange with an adjustable lens, and we'll, put that in the sulcus. We're going to see how he does over the next week, 2, 3, before going down that rabbit hole. But, when somebody comes in with that storm cloud over them, it's like, you are so nice preoperatively, and post-operatively, it's like I'm, a bad person. I think the sooner you can get around the table and say, I hear you, this is the same, let's solve this together, the better those days go.
Blake, have you had the rare, or maybe not so rare, hyperope this scenario that Sebastian's describing? I've had this play out, and not necessarily like dysphotopsia, but just it's the hyperopic patient who is 20/20 and feels like you have ended their world. Have you had that happen before, Blake, with a hyperope, that you're just expecting it just to be perfect? I've got a idea of what it is, but I'm just curious if you've experienced that or.
Yeah, I mean, there's something with smaller eyes. I mean, we're always taught to beware of the low myope, but as long as you kind of warn them that they'll need readers and all that stuff. I mean, I think we all look at hyperopes like low-hanging fruit. This is easy, and most of them are that way, in my experience. But it's only occasionally that you get these smaller eyes that it doesn't seem like you can do anything right with. What do you think it is?
I think it's a object minification. They're used to having their world. Basically, this is more philosophical or metaphysical, but all of our reality is just a construct, right? It's like how we construct it in our mind is what it is to us. And I think sometimes when we change the relative magnification or minification in someone's vision, the place that vision is in their visual cortex has changed. So we've sort of changed like their field of view and their relative minification of things, and the world just seems wrong. It's like I know, yes, I can see it, but it ain't right. In Kentucky, it ain't right, doc. I don't know what it is, but it ain't right. And so it takes a long time for their brain to rewire, almost like a multifocal. And I wonder, Sebastian, if you put a 3 diopter, like a minus, 3 on that guy, and made him a hyperope again, if it wouldn't solve his brain issue. It'd be an interesting exercise to reverse his hyperopia, just to see if he's like, oh, what? Yeah, this is great. So, put a -3 on and put him in the foreopter and neutralize him and see if it's not an issue with object, magnification. Just a weird thought.
Interesting. No, yeah, that's absolutely worth a try.
I think a couple teaching points there. The first thing that you did, the validation piece is important. Nobody wants to hear you're doing great, and I'm bad with this because when I walk in the room, I'm just I suffer from toxic positivity, is what my wife calls it. I just things are good. They just are generally good.
It's the best kind of toxicity you can have.
But sometimes when I'm all cheery in there doing my thing, being me, they don't want to hear that. They're like, no, things aren't good. I'm not doing great. Don't say that. And nobody wants to hear that. And then I think the other piece that has always helped me is to get another person in that room as quickly as you can. Hopefully one of their people. Like, hey, by the way, do you have somebody that is your partner or your wife, or can you bring them next time? Because why you can't talk to me? No, I kind of want to go over some things that we can do at home, and I'm curious about kind of how things are placed in terms of the TV and stuff. It always helps me to talk to them. I kind of position it like that, but really, almost always they kind of become your ally, and they're kind of preaching for you at home. And then the third thing that I do with these people that are just unhappy no matter what is I force them to tell me a couple things that they're happy with, right? Because if you said, how's everything going? Everything's awful. The world smells like poop, baby poop, the worst kind. My vision's terrible, blah, blah, blah. But if I get all that. But what I'm going to force you to tell me one thing you like. You used to be +3 hyper before this. Here's +3. Look through this foreopter. You can't see anything, can you? No, you can't. So would you say that your distance vision straight ahead is better now and you can pass the driver's test without glasses? Yes, I can. Okay. And that's one thing that you like, right? And then what happens is the spouse sees those small little tiny letters across on the Snellen chart and they say, see, honey, like, you can see. So those are just little small things that you kind of start to do. But the patience, you have to have tremendous patience and you can't get mad. And sometimes when they're a little bit ugly to me, I get a little bit internal. I have to really fight to kind of speak slower, speak softer. I stare a lot. Like I'll do a lot of uncomfortable pauses where I'll just kind of look into their eyes very quietly and answer very respectfully and quietly, so it kind of takes all the air out of the room. It's kind of awkward with those grumpy kind of veterans and people like that. God bless our veterans, but sometimes can be kind of grumpy and difficult as patients, and you want to do well for them. So I don't know. Those are some of my thoughts with that one, Gary.
Yeah, I think that we all will have these things we go to when there's like nothing wrong that we can see with a patient. We have to tell them some sort of plan for resolution or next steps. I think that is a whole category of professionalism that is underrated. Of what do you do when you are sitting in front of a patient, their eye looks perfectly normal, and they are unhappy with your work, but there's literally nothing you could have done differently, knowing like what you knew at the time, even knowing what you know now, maybe there's no reason to think you would have done anything differently. So generally what I tell people when I'm forced into a situation like this is I say, okay, there are two categories of problems that I see with patients. The first category, I start talking about like the patients who have a blinding infection after cataract surgery, and people who have retinal detachments, and people who have horrible problems that there's no fix for. And I say, now that's the bad category. We don't, and thankfully everything went well with surgery, and the problems you're having are over here in this other category where we have a lot of things that we can do. So it kind of like Blake, what you're saying, resetting the conversation. You're saying, okay, tell me some things that are positive. I'm trying to kind of almost go the opposite way of like, there are definitely areas in patients that I see who are really unhelpable. And thankfully, because your surgery went so well, we have so many different options, and we just have to start going through the checklist of things to get you to where you're happy. And I do tell them, I say, we see with our brains, not with our eyes. And so just because I see everything, we're focusing things on your retina, and that's kind of my job as a refractive surgeon, is get those light rays focused on your retina. The job doesn't stop there. And it may just be that your brain, just like if you had a knee replacement or a hip replacement, it's going to take some time to walk again and feel comfortable with the new equipment in your body. This is something that you're going to have to get used to. And so I'm going to ask for a little bit of patience. It's not that I'm trying to tell you I know it's perfect. I know it's not perfect. but we're going to walk with you through this. And that at least gives them some sort of perspective, like could be worse. It does take time, just like giving them an analogy that they can chew on a little bit. Most of these people who have had cataract surgery know someone who's had a knee replacement, hip replacement, et cetera. Sebastian, what other things do you do in those situations?
Yeah, so in those, just like Blake said, finding an ally, if somebody's unhappy with their near vision, show the near card. Here, look, you can do it. They're J3, look this. And then the wife or whoever says, come on, you're being a little bit too picky. I also like to explain, over explain. My team gets a little annoyed. It's like, you don't really need to get into an effective lens position with that person. But I find that helps them to have a construct, and think about and understand why things aren't quite right. So, oh, my lens didn't sit right. And use analogies probably ad nauseum, but it's like shoes. You're 9.5 or 10. We got to pick one. You're not a 9.5 or a 10, but we got to pick one of the two. So I think those are the things. And we have an eye trace, which is something that's very helpful to show people. And I go back to the before. Hey, this is where we started. This is what we did. This is why we did what we did. Remember, we talked about that. And then I tend to help at least have them understand how we got there. And then, like you said, being focused on, all right, now where do we go from here? And once it becomes clear they need to do something, I think the sooner you do it, the better.
Yeah, the funny thing is that if you put in the time to do this, even though it's laborious and it sounds awful, and all the busy surgeons listening to this podcast are like, this is just the bane of my existence, they really can become your happiest patients at the end of the road.
Yeah, for
they
sure.
really can. And then
Yep.
almost always they're like, man, thank you for sticking it out. I know it was not easy, but and so I don't know if it's worth it to go through all that to get that pat on the back, but sure, it feels good when you say, I'll see you in 6 months.
I tell patients when they're not happy, I said, the last thing I need is a patient who I've done surgery on walking around this town telling people they're not happy. So I just tell them, like, if you don't quit on me, I won't quit on you. We'll do everything we can. I'll send you anywhere. I'll find a person. And I mean, I don't know if you guys have been to a regular doctor's office lately. It's not good out there. It's hard to find good doctors who, and this is not a criticism, it's because the system is so broken that primary care doctors, it's hard to find a good one. They're trying to see 1 million patients. Nothing against nurse practitioners or PAs. They're lovely. And sometimes I feel like I even get just amazing care from them, but it's always like trying to find someone who will listen to you and actually engage and take your problem seriously and take care of you as if you were their only focus. That is so hard to find nowadays. And honestly, like as a physician, that is what I strive to do. I mean, if someone's unhappy with me, I can't hardly sleep at night. I mean, maybe I need to go to therapy over that, but I hardly take it.
Yeah, I think that we all very much share that, Gary, and if people know that you care, they'll be patient with you. They'll work with you. And I think sometimes we get a bit of not maybe our reputation, but the perception is, hey, you're on a billboard, you shoot lasers and shoot fireworks, and everything's rainbows and butterflies. But I think I really love sharing with you guys and listening to you and saying, hey, good, I'm not the only person who's having these challenges. And sometimes the more effort you put into something, the more rewarding it is on the backside. So and having these people you fight with and you fight for and bond with, they can be your best marketing people because they know you will not give up on them. You'll keep going and going. So they'll tell you, I was mad at you, but I'll send 10 friends now. I'm like, great.
Exactly.
Awesome. I appreciate it, Sebastian. It looks like you got to go back into the OR, buddy. Thanks for spending some time with us, man.
I got one more case to do, but I'm really sorry to go. But duty calls, and it's really I appreciate you guys letting me come and hang out, and can't wait to see you guys in person soon.
Absolutely. All right, it's been Ophthalmology Off the Grid with Blake and Gary. Until next time, bye.
Go Tigers.
Thanks for listening to Ophthalmology Off the Grid, and thank you to our guest, Dr. Sebastian Heersink. Stay tuned for new episodes to hear more horror stories from top ophthalmic surgeons.